The immunologic pathways in the skin are not surprisingly complicated because your skin is your primary immune organ. I mean, it is separating us from the environment. It is what faces the outside world. It is what faces infections and irritants. In the non-lesional skin of atopic dermatitis, the disrupted barriers and allergens can cause activation of the immune system. And if we could think again about the histology that we saw, the histology of atopic dermatitis, to me, as a dermatopathologist, looks identical to the histology that I would see in contact dermatitis, allergic contact dermatitis, or even perhaps in an irritant reaction. And so I suspect that the primary immune pathways are going to be very similar. In the acute phase, you have inflammation and resulting itching. I think some people believe the itching comes first, and that disrupts the barrier. People scratch, and that causes the inflammation. But I believe that it's the inflammation that comes first, at least in part because we see so many immune molecules in the genetics of atopic dermatitis. The other reason is because, I see these patients who have pityriasis alba, and they're not scratching. They're having a change in their pigmentation due to, I believe, underlying inflammation. So it seems to me it's the inflammation that comes first and not the itching. But certainly the itching is important, and you have cytokines involved in the itch, like interleukin 31. The cytokine cascade activates T cells, and then you move on to a more chronic phase where other cytokines may be involved, creating the lichenification and the thickening of the epidermis and the long-term changes that we see in atopic dermatitis. The T helper 2 pathway that gets activated is a key target for improving the disease. So you have allergens that are being picked up by dendritic cells, and they're activating T helper 2 cells. And these cells are producing interleukin 4 and interleukin 13, which have an array of secondary effects on the immune system and the skin, ultimately leading to B cells and IgE, which potentially could be another target. Although, as we'll discuss, late phase targeting of IgE does not seem to be nearly as effective as targeting earlier cytokines like interleukin 4 and interleukin